Welcome to the first of a series of podcasts that we're putting together, supported by the Harold Vail Visiting Professorship in partnership with the Ottawa Regional Cancer Foundation. And this series is looking at various clinical issues that you'll see in your daily practice. And we're bringing in visitors from around the world, well-known researchers and clinicians, to help us understand these clinical issues. And the first one today is going to be focusing on the issues of cachexia in cancer and anorexia. And our special visitor is Professor Vickie Baracos, who is professor and holds the Alberta Cancer Foundation Chair in Palliative Medicine at the University of Alberta in Edmonton. And we're pleased to have you here as a world-renowned scientist in this area. And so I'm sure we'll learn a lot from Vickie in the next 45 minutes of conversation. And in the panel we have Dr. Peter Lawlor. Peter is the Associate Professor of Palliative Medicine at the University of Ottawa and Medical Director of the Palliative Care Unit at the Elizabeth Brewer Hospital here in Ottawa. And we have Dr. Martin Chasen, who is an oncologist and a palliative care physician, and is associate professor in the Division of Palliative Medicine in the Department of Medicine at the University of Ottawa. Martin has a special interest in the area of palliative care rehabilitation and cancer rehabilitation, and is also medical director of palliative care services at the Ottawa Hospital Cancer Centre. I'm José Pereira, and I'm the head of the Division of Palliative Care at the University of Ottawa and the medical chief of palliative care at the Elizabeth Brewer Hospital. Welcome, and I guess we can start. Perhaps, Vickie, to get the ball rolling, if you could share with us what from your perspective, what is the definition of cachexia?
Well, maybe I could start by telling you how I come to be thinking about it. My background is in human nutrition and metabolism, so I studied nutrition and metabolic biochemistry, and I've had a very long-standing interest in anything that has to do with involuntary weight loss, so wasting syndromes, and most particularly wasting of skeletal muscle, which is an important subset of that. I started out my career to date in Winnipeg, Manitoba, Canada. I was educated in Nottingham, England, and in Boston, Massachusetts. And I just finished my 25th year at the University of Alberta, where I have been in the departments of nutrition and most recently in the Department of Oncology, where I have devoted my entire effort to malnutrition and weight loss as experienced by people with cancer.
And in all these years, all the work you've been doing, at this point in time, what would you say is cachexia? Because I know it's become a bit controversial, right, in terms of the definition of what cachexia is in cancer.
Cancer cachexia is defined by everybody in the simplest common sense, which is defined by involuntary loss of weight. And so that part of the definition stands to this day since Hippocrates. It has been changing over time in the sense of what weight is being lost and why it's being lost, like what are the underlying causes in different conditions where wasting occurs. I think that probably the most unique current thing is a group of people pushed in this direction internationally has tried to write definition and diagnostic criteria for cachexia of different diseases. And that group of people have come up now with the notion that cachexia is defined as loss of skeletal muscle, either with or without loss of fat mass. This allows for the thing we always understood to be cancer cachexia to be included in the definition. So when people waste away globally and land up being emaciated and have lost their muscle, their adipose tissue, who have lost everything, those are still defined as being cachectic. However, the scope of that new definition allows that someone might lose their muscle and not necessarily their adipose tissue, might end up having a large body weight with an underlying loss of muscle of great consequence. And that would also be included in the definition.
So I think what you're saying is that there'll be some patients with cancer who may have a normal body mass index and yet be in some trouble, and others with a body mass index that is low and be in trouble.
That's correct. So if I like to poll palliative care physicians and family physicians and ask them, what is their perception? What is your perception of the body weights of the patients that you see currently compared to those you might have seen a decade ago?
I suppose, commenting as a palliative care physician, we see a mix really of some very profound and obvious cachexia, but then we would see patients as well who would be, I suppose, have a relatively high BMI, body mass index. So I think leading into your question, the suspicion is that some of those patients would be those that would have less muscle mass, in other words, would be sarcopenic, but yet would have an apparent excess of adipose tissue, relative.
I don't know if you maintain a database on such things, but in Edmonton at the Cancer Center, we've managed to capture the body weight, the body mass index, and the weight loss history of the last 5,000 patients who were referred with metastatic solid tumors, and the last 2,000 patients who were referred to the regional palliative care program in whichsoever consult service of that program they were seen in. And that contained some big surprises. One big surprise is that the body weights of newly presenting cancer patients are very high. So it's not unusual to see mean body mass index of 28, 29, 30, even in people with frankly metastatic disease at the time they're diagnosed at that stage. And in Edmonton, the mean body mass index at 1 month preceding death is almost 25. So it means that there are a larger number of people with heavy body weights, and some of those people undergo quite massive weight loss. But it's a shift. It's a shift from, and it's part of a shift, I think, representing the way populations in Canada, the average Canadian has increased their body mass index by 2.5 units in the last decade. So we're all heavier.
So in practice, what does that relate to in daily practice? Important to monitor weight and to start with a baseline weight, and not to wait until someone is profoundly cachectic, profound weight loss before intervening or do something about that. And I guess the question related to that is, well, what do we do about that?
Well, in daily practice, I think people are scratching their heads on this because it's easy to understand if you speak with a group of oncologists and say, well, when you have a patient who comes to you and you inquire about their history of weight, what degree of weight loss do you understand to be of some importance? What's your answer to that question?
Well, I have a sense of what the oncologist might give as an answer, which would probably be something in the region of 20%.
10%.
Well, we have oncologists here.
10%. So 10%, that's, if you take a disease like small cell lung cancer,
yeah,
and you look at the prognostic factors, the three main ones are performance status, disease extent, and the presence or absence of 10% weight loss.
Okay, we've got two bids, 20%, 10%. Would you?
I'll go with 15.
However, and I'm sure Vickie will tell you that it doesn't necessarily mean that if you have a 5%, that the patient can't be cachectic.
This is 5% or 10% over how long a period of time?
Well, these are the questions. Over how long a period, and from what point of departure? So other things that we're learning now is that it's easy for a patient who has been very heavy all their life, and the physician treating a patient who's been heavy all their life, to look at them and go, well, maybe it's not such a bad thing. So one thing you'll encounter is very heavy people who might have lost a great deal of weight in context of a cancer diagnosis and not be upset or frustrated or even particularly worried about it. They may undertake to reinforce or maintain that weight loss when it first starts to happen, because they have struggled to get weight off themselves, perhaps for a long time, usually unsuccessfully.
So can you guide us, for those of us in clinical practice, how do we best assess cachexia, other than observing the patient, getting a figure for body mass index? Are there other assessment methods that we ideally should be looking at in clinical practice?
The two benchmarks that I think everyone in the cancer cachexia field would agree to at this point in time is that if the body mass index is less than 22, there's a problem, and it's because of the weight-losing nature of the illness. In fact, heavy body weights are protective. So you can think of people with a body mass index greater than 22 as being relatively well off financially, vis-a-vis their body energy reserves. So there's the absolute BMI, and then the issue of loss. And the large magnitude loss, 20%, is a very important prognostic factor for anybody at any body weight. So 20% weight loss, what is in the common toxicity criteria.